Hello everyone, I welcome you all to yet another one important and interesting session, Mandibular Nerve Anesthesia Techniques. When obstacles arise, you change your direction to reach the goal, but you do not change your decision to get there. All those patients who present to you might not present with an ideal situation with complete mouth opening or adequate mouth opening. Some might present with reduced mouth opening or inadequate mouth opening. In such situation, even if we have to proceed with the treatment in such cases, we might need an alternate to our classical nerve block technique. So, let us see about another technique, Vazirani-Akinosi closed mouth mandibular block. So, this is also known as closed mouth nerve block because this is indicated in such patients who has reduced mouth opening. This is also known as tuberosity technique. The primary indication remains those situations where the patient has limited mouth opening. Nerves anesthetized in this technique include inferior alveolar nerve, incisive nerve, mental nerve, lingual nerve and your mylohyoid nerve. The areas anesthetized in this technique include mandibular teeth to the midline, body of the mandible and the inferior portion of the ramus of the mandible, buccal mucoperiosteum and mucous membrane anterior to the mental foramen, anterior 2/3 of the tongue and floor of the oral cavity in the ipsilateral side of injection, and the lingual soft tissue and periosteum, which is supplied by our lingual nerve. The indications of this technique, as we discussed earlier, includes the limited mouth opening, multiple procedures on the mandibular teeth, inability to visualize the landmarks for classical IA and B because of maybe anatomically large tongue, and the contraindications as for any other nerve block technique includes infection or acute inflammation in the area of injection, patients who might bite their lip or tongue such as young children and physically and mentally handicapped adults, inability to visualize or gain access to the lingual aspect of the ramus. The advantage of this technique being relatively atraumatic, patient need not able to open the mouth wider, fewer post-operative complications and a lower aspiration rate than IA and B. Provides successful anesthesia where a bifoot inferior alveolar nerve and bifid mandibular canals are present. The disadvantages being difficult to visualize the path of needle and depth of insertion, and we might not be able to get a bony contact as with our conventional IA and B, and the depth of penetration somewhat arbitrary. Potentially traumatic if the needle is too close to the periosteum. Complications include hematoma in less than 10% of the patients, trismus which can occur rarely, and transient facial nerve paralysis if we use very long needle and the solution is being injected into the parotid capsule. Coming to the technique, the landmarks for this technique include mucogingival junction of our mandibular second and third molar, maxillary tuberosity and the medial aspect of the ramus, and the target area of this technique includes the medial aspect of the ramus. So, in this technique we have to ask the patient to close the mouth and insert the needle into the mucosa between the medial border of the ramus and the maxillary tuberosity at the level of cervical margin of maxillary molars. So, here if the patient mouth is being closed, we will be keeping the syringe medial to the ramus of the mandible at the level of cervical margins of maxillary second and third molar near the tuberosity level. This needle should be held parallel to the maxillary occlusal plane and the needle is advanced approximately 23 to 25 mm inside, and it should be located in the middle part of the pterygomandibular space near the inferior alveolar nerve and lingual nerve. So, first we have to identify the mucogingival junction of the maxillary second molar and third molar region, keeping our syringe needle parallel to the maxillary occlusal plane, and we are starting to insert the needle medial to the ramus of the mandible and proceed of about 23 to 25 mm. So, upon insertion the needle lies in the pterygomandibular space in the middle region almost near our inferior alveolar nerve, and once aspiration is negative, we have to deposit about 1.5 to 1.8 ml of local anesthetic solution slowly over 60 seconds. In this technique, the orientation of the bevel is very critical and it is very important, and it has to be oriented away from the bone, means it should be the bevel of the bone should be oriented towards the midline. Coming to the next technique, this is Gaugate's technique. Gaugate's technique is also known as open mouth technique. It has the high success rate approximately 99%. It is also called as true mandibular nerve block because it provides sensory anesthesia to virtually the entire distribution of our mandibular nerve of trigeminal nerve, including inferior alveolar nerve, mylohyoid, lingual, mental, incisive branch, auriculotemporal and long buccal nerve. Areas anesthetized being mandibular teeth till the midline, buccal mucoperiosteum and mucous membrane on the side of the injection, anterior two-third of the tongue and the floor of the oral cavity, lingual soft tissues and periosteum, body of the mandible, inferior portion of the ramus, skin over the zygoma and posterior portion of the cheek and temporal regions. As we can see in this picture, this is very important, being the areas highlighted with the yellow or shaded with the yellow color depicts the areas anesthetized after achieving our true mandibular nerve block, which is our Gauge technique. So, here you may also note that the areas being innervated by our long buccal nerve is also getting anesthetized in the same technique. Indications for this technique being multiple procedures on mandibular teeth, when buccal soft tissue anesthesia from the third molar to the midline is necessary, when lingual soft tissue anesthesia is necessary, and when a conventional inferior alveolar nerve block is unsuccessful. Contraindication being infection or acute inflammation at the site of injection, patients who might bite their lip or tongue such as young children and physically or mentally handicapped patients, patients who are unable to open their mouth very wide. So, in contrast to our Vazirani-Akinosi technique, which is a closed mouth, this Gauge technique is a open mouth technique because it necessitates the patient to open their mouth very wide to achieve the proper anesthesia. Advantages of this technique being requires only one injection, the buccal nerve block is usually unnecessary, high success rate greater than 95% with experience, minimum aspiration rate, few post-injection complications and provides successful anesthesia where a bifid inferior alveolar nerve or bifid mandibular canals, which is an anatomical variation, might present. Disadvantages being lingual and lower lip anesthesia is uncomfortable for many patients and is possibly dangerous for certain individuals. The time of onset of anesthesia is comparatively or relatively longer than our conventional IA and B, primarily because of the size of the nerve trunk being anesthetized and the distance between the site of deposition of local anesthesia and the presence of nerve trunk, approximately 5 to 10 millimeter. There is a learning curve requirement for this technique which requires experience for achieving a complete anesthesia. The positive aspiration rate for this technique is very less, which is about 2%. Alternatives for this technique being IANB and buccal nerve block, Vazirani-Akinosi closed mouth technique, incisive nerve block or mental nerve block as it necessitates supraperiosteal injection. In this technique, the landmarks being maxillary second molar mesiopalatal cusp and head of the condyle, and extraorally the tragus of ear. The mouth is open wide as possible and the needle is inserted high into the mucosa at the level of second maxillary molar just distal to the mesiolingual cusp or the mesiopalatal cusp, using the intertrachic notch as the extraoral landmark to help reach the neck of the mandibular condyle. So, marking the extraoral intertrachic notch and the corner of the mouth making a plane, we have to approach from the contralateral side from the premolar region and the needle placed in the direction parallel to the plane formed by the corner of mouth and the intertrachic notch. Advance the needle in a plane from the corner of the mouth to the intertrachic notch from the contralateral premolar side until it contacts the condylar neck. Withdraw the needle slightly and perform aspiration to observe whether the needle is in a blood vessel, and if it is negative, slowly inject the solution. Have the patient keep the mouth open for a few minutes after injection to allow the anesthetic solution to diffuse around the nerves. So, in this picture we can see the tragus and the intertrachic notch in the below picture and the corner of mouth. So, marking an imaginary plane drawn from the corner of mouth to the intertrachic notch, the syringe is oriented in the same plane parallel to it, oriented from the opposite side or contralateral premolars in the same direction. So, here comes our maxillary second molar and the needle kept just below the mesiopalatal cusp of maxillary second molar, we are approaching and the needle has to be inserted in the same direction. So, as we proceed inside deep, our needle finally reaches the neck of the condyle. So, after aspiration 2 times, and if it is negative, we have to slowly deposit the solution and we have to wait for at least 5 minutes for getting proper anesthesia. So, we have to evaluate the signs and symptoms, and once they are fine, we can proceed ahead. Moving on to next nerve block technique, which is the mental nerve block. So, as we know, mental nerve is a branch of our mandibular nerve, and it is a continuation or branching from the inferior alveolar nerve from the mental foramen. So, it is a terminal branch of inferior alveolar nerve as it exits from the mental foramen, providing sensory innervation to buccal soft tissue anterior to the mental foramen and to the skin of the lip and chin. So, how to locate the mental foramen intraorally? So, we have to keep our finger pushed inside the vestibule, run it along from the first molar region anteriorly. So, we might be able to find some roughness or concavity and some depression over the mental foramen region. Typically, the mental foramen presents just apical to the mandibular second premolar or between the apices of mandibular first and second premolar. So, once the mental foramen is located, we can proceed ahead with the technique. The areas anesthetized with this technique include buccal mucous membrane anterior to the mental foramen and to the midline and to the skin of the lower lip and chin. So, the thing we have to note here is only the mucous membrane and soft tissue over the lip and chin region gets anesthetized, whereas the pulpal tissues from the premolar till the incisor is not being anesthetized with this mental nerve block technique. Indications for this technique including soft tissue biopsies, suturing of soft tissues, contraindication being infection or inflammation at the site of injection. The advantage being easier and higher success rate, usually atraumatic. The disadvantage is rare presence of or rare presentation of hematoma. Alternatives for this technique includes local infiltration, periodontal ligament injection, intraseptal, Gaugate's inferior alveolar nerve block technique. Positive aspiration rate for this technique is 5.7%. So, the technique is how it is done. Locating the mental foramen is the first thing we have to do, and after locating the mental foramen, insert the needle into the mucosa at the mucobuccal fold at the location of mental foramen. Perform the aspiration with the syringe or needle held parallel to the long axis of the tooth. After negative result, slowly inject the anesthetic solution. Wait for 2 to 3 minutes, and once the subjective signs and symptoms are achieved, proceed ahead. Moving on to next nerve block, which is a incisive nerve block. So, this is very closely associated with the mental nerve block with very minimal difference. So, again it is a terminal branch of inferior alveolar nerve after giving out the mental nerve branch in continuation within the mandibular canal. It originates in the mental foramen region and proceeds anteriorly. So, this incisive nerve block is good for bilateral anterior anesthesia, not effective for anterior lingual anesthesia. Nerves anesthetized are the incisive branch and mental nerve branch. Areas anesthetized including mandibular labial mucous membrane and buccal soft tissue, skin over the chin and part of the lower lip, and the pulpal tissues of incisors, canine and bicuspid. Indication includes anesthesia requirement in the pulp or tissue required anterior to the mental foramen. As usual, the contraindication is injection or inflammation at site of injection. It has higher success rate and higher pulpal anesthesia without the lingual anesthesia, and the disadvantages being there is a requirement for additional lingual anesthesia when this is opted. The positive aspiration rate is 5.7%. Again, the complication is rare chances of hematoma formation. So, the variation or the difference between mental nerve block and the incisive nerve block lies, we have to locate the mental foramen, we have to place the syringe bevel facing towards the bone, aspirate, and we have to inject approximately 0.6 to 1 ml of solution, whereas in mental nerve block we will be leaving it as it is. Whereas in this incisive nerve block technique, we have to give either intraoral pressure or extraoral pressure around the mental nerve region in order to facilitate the diffusion of the deposited local anesthetic solution within the foramen to anesthetize the incisive nerve branch. Hope you have understood. So, just a summary clip about the recommended volumes of local anesthetic solution for mandibular injection techniques. For inferior alveolar nerve block technique, recommended volume is about 1.5 ml. For long buccal nerve block, recommended volume of injection is 0.3 ml. For Gaugates, it lies about 1.8 to 3 ml. For Vazirani Akinosi, it is about 1.5 to 1.8 ml. For mental nerve block, it is 0.6 ml. For incisive nerve block, it is 0.6 to 0.9 ml, and for infiltration, it is the same 0.6 to 0.9 ml. Vazirani Akinosi nerve block technique. The anatomical landmarks includes the mucogingival junction of maxillary second and third molar region or the cervical level, which stays in this level, our maxillary tuberosity and the medial side of the ramus. So, the Vazirani Akinosi technique is indicated for patient with limited mouth opening. So, in this situation, the needle has to be placed parallel to maxillary occlusal plane. So, it has to be placed parallel to maxillary occlusal plane. The orientation of bevel is being critical. It has to be placed medial away from the bone, means towards the midline. So, we have to see for the mucogingival junction of maxillary second and third molar region near the tuberosity, and the syringe held parallel to the maxillary occlusal plane and medial to the mandibular ramus. We have to proceed further inside. So, approximately the depth of insertion being 23 to 25 mm. So, here upon insertion you can see the needle is located almost near my inferior alveolar nerve region. So, once it is the adequate depth of insertion is achieved, do the aspiration. Once it is negative, slowly deposit about 1.5 to 1.8 ml of solution over 60 seconds. Gaugates nerve block technique or open mouth or true mandibular nerve block technique. So, this technique necessitates the patient to open the mouth wide as possible. The anatomical landmarks include mesiopalatal cusp of maxillary second molar, which will be almost in this region, contralateral premolar and the head of condyle or the neck of the condyle. The target area being the neck of the condyle where the lateral pterygoid muscle gets inserted. So, asking the patient to open the mouth wide as possible, we have to take our needle, a long dental needle, orienting to a plane parallel to an imaginary plane formed by corner of mouth and the intertrachic notch, which will be approximately in this orientation. So, corner of mouth will be present here and the intertrachic notch present here, which you can refer from the figure. The needle orientation will be parallel to this imaginary plane. So, for anesthetizing in the left side, I have to approach from the contralateral, that is right side premolar region. My needle held just below the mesiopalatal cusp of maxillary second molar and I have to proceed forward. So, as I proceed further, my needle is directed towards the head of the condyle or neck of the condyle, just lateral to the insertion of lateral pterygoid muscle. So, slightly withdraw and aspirate. Once it is negative, slowly deposit the solution of about 1.8 to 3 ml. Then slowly withdraw the needle, recap it safely, and ask the patient to keep the mouth wide open for few seconds in order to facilitate diffusion of local anesthetic solution. mental nerve block. So, for mental nerve block, intraorally we have to identify the mental foramen. So, mental foramen lies directly beneath the apices of second premolar and first premolar region. So, intraorally we have to stretch the buccal mucosa or the vestibule, keep our finger over the first molar region deeply placed and gradually run it anteriorly. So, when you run near the mental foramen, you will feel a concavity or irregularity or some depression where our mental foramen lies. Taking our syringe and needle held parallel with bevel facing towards the bone, we have to reach near the mental foramen. We have to once reaching the mental foramen, aspirate it, once it is negative, slowly inject of about 0.6 to 0.9 ml of solution over 30 to 60 seconds. The difference lying in incisive nerve block is almost the same, with an extra step being application of pressure either intraorally or extraorally for about 1 to 2 minutes over the site of injection to facilitate the diffusion of local anesthetic solution inside the mental foramen. I hope you have learnt from this session. If you have any questions, please feel free to contact in this below mentioned email ID. Thank you.